Hello friends, in this video we are going to discuss about IUGR, Intra Uterine Growth Restriction or Retardation is a condition in which a baby doesn't grow to normal weight during pregnancy. There can be many causes, and fetal causes can be inborn error of metabolism or congenital anomalies, and maternal causes can be PIH or repeated UTI, and placental causes can be fenestrated placenta or any calcification in the placenta. So in IUGR, most of the cases can be idiopathic. So we don't need to go deep into the causes. Mostly 60% of cases are idiopathic. We don't know the cause, it's unknown. Let's see how does the IUGR get diagnosed. If the baby is just in the abdomen, we say it is 12 weeks, and if the baby at the level of the umbilicus here, it is 24 weeks, and if the baby is at the level of giphisternum, we say it is 36 weeks. Suppose the pregnancy is to be at 32 weeks at this height, but the height is only 28th week clinically. It is supposed to be at this height of 32 weeks, but it's here, only here at the height of 28 weeks. So there is a clinical lag. We can say there is a lag of 2 to 3 weeks. So there is clinical lag of 2 to 3 weeks. So let's see the another lag, growth short lag. Let's see the growth short lag. This is the gestation age and this is the femoral length in millimeter. And this is the curve of normal pregnancy, that is 50th percentile. And some babies are larger than this 90th percentile, and some babies are smaller, that is 10th percentile, this is 9. So if the growth of the femoral length on the ultrasound over the whole pregnancy is following these patterns here between 10th and 90th percentile, it is normal pregnancy. Sometimes pregnancy might be bigger than 90th percentile, and this is called a macrosomia. And even smaller than the 10th percentile, and these babies are small to gestational age. Macrosomia, they weigh more than 4,000 grams, and small for gestation age. Babies can be it can be due to babies can be constitutionally small. Constitutionally small means they have small parents, so there is small babies. And other thing is IUGR. So IUGR babies are smaller than the 10th percentile. Let's see which is the first organ to show the lag. The nourishment to the baby is less, so the abdominal circumference is the first affected in the baby, next to the humeral length, and then the femoral length. Abdominal circumference is the first affected in the IUGR babies. The last and least affected by retardation process is the diameter of the head, because there is preferential circulation to the brain. That's why there is a brain sparing effect when there is a stress on the baby like IUGR. So the brain is spared, the nourishment is keep on going. However there is a lack of nutrition. The brain is getting continuously somehow the nutrition. So due to the brain sparing effect, last and least affected by retardation process is the diameter of the head. So last parameters to be affected by IUGR is the bipedal diameter and the head circumference. If you see the bipedal diameter and head circumference in IUGR patients, in IUGR babies, they are exact to the normal gestational age. They show the exact gestational age. So single best parameter in the third trimester to assess the gestation age or the diameter of head, like bipedal diameter or head circumference or transcerebellar diameter. Let's see the difference in early onset IUGR and late onset IUGR. Early onset IUGR, it starts early and has poor prognosis, and it may be due to chromosomal defects, or due to congenital anomalies, and late onset IUGR are due to PIH or infections like UTI or chorioamnionitis. In early onset IUGR, the babies are symmetrically small babies, and in late onset IUGR, asymmetrical babies. Symmetrically small babies in the early onset IUGR, asymmetrical in the late onset IUGR. Here, head circumference by abdominal circumference, the ratio is 1 in early onset IUGR because all parameters have been compromised from the beginning of pregnancy. So in early onset IUGR, this ratio is 1, and in late onset IUGR, head circumference by abdominal circumference, the ratio is more than 1 because abdominal circumference will be compromised first, and then head circumference will be preserved because of the preferential circulation. I said brain sparing effect. So the ratio is more than 1. Here the prognosis is much better. In early onset IUGR, EFW is estimated fetal weight and FL is femoral length. So the ratio of estimated fetal weight over femoral length cube is 8.3, and this is known as ponderal index, and this value of 8.3 is always maintained in early onset IUGR, so there is good prognosis. In late onset IUGR, estimated fetal weight over femoral length cube is less than 7. This is much lesser than normal because the estimated fetal weight is reduced, but the femoral length is maintained for some time, so the value differs. It is lesser than normal, so there is poor prognosis in this case. If you've seen a case of IUGR, you have been advised to give high protein diet, high calorie diet, give fruits, veggies, nuts. If you are working in a metropolitan city and you go and see the patient, you will be surprised that you return this diet for a person who looks absolutely healthy. So diet is almost always never the cause. Even the low socio-economic status people, they deliver 3 kg, 3.2 kg babies. They deliver healthy babies, right? Because the baby is like a parasite. Baby has placenta which stuck to the mother, and with that placenta, baby goes on sucking nourishment from the mother, isn't it? If mother eats well, good for the baby. If mother doesn't eat well, it's still good for the baby. Mother will become malnourished. She will have anemia and all. So tell the mother, you eat well for yourself, baby will take care of himself. And if the placenta is bad, like placenta is small or there is calcification in the placenta, this placenta can suck only as much as only capacity that the small calcified blood vessels do. So if there is a cause in the placenta, if there is calcification or placenta blood vessels or calcified because of due to the placenta, the baby will become small and malnourished, right? So let's see the treatment of IUGR. For management in IUGR, rest in lateral position is the most important thing. Advise the mother to rest in lateral position. It will take the weight of the baby away. She should be lying on the side. Thus venous return increases and the output increases. And obviously give adequate diet. And the best management is surveillance. Get the patient in the hospital, admit the patient, Monitor the patient, see the heart rate morning and evening, and do the test, do the Doppler. We will see that lung gets matured and the weight may increase. So the one important thing in IUGR is surveillance antepartum and surveillance intrapartum. Let's see very brief about surveillance. The daily fetal movement count should be more than 10 in 12 working hours, and non-stress test should be reactive after 32 weeks. Non-stress test is the sympathetic and parasympathetic nervous system's balance of the heart rate of the baby. So baby is lying down, parasympathetic tone is more, the heart rate is around 140, baby is moving around. Put a probe on the abdomen of the mother. That movement will increase the heart rate. The increase should be more than 15 beats from the baseline and last for more than 15 seconds, and this should happen at least twice or more than twice or more in 20 minutes observation time. So that's all, and thank you.